So good morning, everybody. I hope you had a good weekend. It's my pleasure this morning to introduce today our speaker on Grand Rounds, Lynn McGrath. Most of you have probably met him in the operating room or in the hospital here. He's our fellow in minimally invasive spinal surgery this year. Lynn is originally from New Jersey. He went to college in Dartmouth and started his neurosurgical residency after medical school in Florida in Seattle, where he trained with our former resident, Christoph Hofstetter, and others that we're all very, very familiar with. His original interest was neurotrauma and head trauma and also spinal trauma. And obviously training in Seattle, he got an extensive exposure to those areas. He also trained in endoscopic surgery, and he's an excellent technical surgeon, as we've experienced over the last few months. But his real passion, I think, is really machine learning and neurotrauma. He's been very entrepreneurial over these years. If you look at his CV, he's got multiple awards for innovation. He's got grants from various organizations for the work that he did with TBI diagnostics and machine learning. So that said, we're very excited to have you here, Lynn, and we're looking forward to your presentation on machine learning in neurosurgery.
Thank you, Dr. Hartle. Thanks for the nice introduction. And thank you for having me to talk today. As Dr. Hartle said, I'm the spine surgery fellow here, but my talk's not on spine surgery. It's on one of my other passions, which is developing machine learning tools to improve the care that we give to neurosurgical patients and to deepen understanding of neurological functioning. So we're going to talk a little bit about the history of machine learning research, describe in basic terms how exactly the technology works, and finally to discuss the specific application of the technology that I've been focusing on. First question most of you are probably asking is, what is machine learning? And I like this basic description offered by Arthur Samuel, who said it's just the ability of computers to learn without being explicitly programmed. And this capability has been a dream of computer programmers from the very beginnings of the field. Ada Lovelace, a mathematician born in 1815, is known as the world's first computer programmer. In 1840, she developed the first algorithm run in the world's first computing machine, Charles Babbage's analytical engine. She's also considered the first person to fully grasp the potential of computers for applications beyond mere calculation, postulating here about the potential to compose music, for example. It wasn't until 1956, however, that a group of ambitious young computer scientists convened at Dartmouth, and this vision was first given the name artificial intelligence. The founders of the field outlined a research trajectory and were plenty optimistic, proclaiming that within 20 years, machines would be capable of doing any work that a man could do. I can personally attest, and Justin Schwartz probably can, that this is probably the first and last productive brainstorming session that's ever occurred at Dartmouth. And things didn't quite go as planned. We entered into a period of time of relative stagnation for the next 40 years in a period known as AI winter. And it wasn't until the 90s when computing power and computational theory caught up and would combine to create the conditions necessary for meaningful progress. In 1996, the cutting edge of artificial intelligence finally burst into the mainstream with Garry Kasparov's chess match against IBM's Deep Blue supercomputer. It was a formidable opponent. It had loaded 700,000 grandmaster games into its memory, could calculate 200 million positions per second and calculate 20 moves ahead. Amazingly, Kasparov won their first meeting 4-2. Unfortunately, he fell to IBM in the rematch, which was known popularly as the brain's last stand. In 2011, Ken Jennings took on IBM's Watson, and the next big display of AI power in the public sphere. Watson was much more impressive because the task that it was dealing with was much more complicated. He had to answer a question posed, search its memory for answers, and then rank those answers in order of probability without any human or internet connection. Watson blew Ken Jennings away in another defeat for humans. The most recent demonstration of AI dominance in the public sphere was in Google's AlphaGo demonstration. Go is a game that's been played in China for 3,000 years and is considered the most complex game in the world. There are 10 to 107 possible board configurations, which is more than there are atoms in the known universe. And AlphaGo beat the #1 ranked world player, who described AlphaGo as like a god of Go, and that he was struggling to understand the moves that had beaten him, and he was sure that computers were indicating that humans were completely wrong in the rules that they had developed as to how to play the game over the past 3,000 years. So all this success has led to an immense amount of hype in the mainstream media, as well as from those in the best position to know, like Bill Gates, who said that a breakthrough in machine learning would be worth 10 Microsofts, and Tony Tether at DARPA, who is comparing machine learning to the new internet. The approach to machine learning that I'm taking is what Mark Zuckerberg here is describing, and he's talking about being focused on developing AI services that have better senses, like seeing, hearing, and processing language than people do. Why has AI become so powerful after such a long period of stagnation? Well, it's because of the affordability of processing power, better understanding of the theory and models that are effective, particularly something called deep learning, and because of the proliferation of sensors throughout society, which are generating massive amounts of data that can be used to train these models. Just to talk a little bit about what deep learning actually is. Deep learning models are loosely inspired by cortical structures and processing style. The model consists of several layers of interconnected neurons, and the neurons are the computational components of the model. You can see in the bottom picture, each neuron receives inputs of various weights. And if those weights combine to overcome what's called the bias of the neuron, that neuron will perform some computation on the inputs, and that result will be propagated forward as the input to the next layer of neurons for further processing. It's kind of like action potentials meeting a threshold and propagating. Here's another look at the overall structure of a neural network, like in a deep learning model. You can see the first layer is called the input layer. These inputs represent features of the data that might be useful in making a prediction. They are multiplied by weights and sent to the first set of neurons for processing. The neurons exist in what are called hidden layers, and these are the computational layers. The neurons process all their received outputs. Their outputs are again multiplied by weights and sent downstream to the next layer of neurons for further processing. The final layer is the output layer, and this is where a prediction is formed based on the particular set of weights, biases, and layers of the given model. All these components can be tweaked to try to achieve more accurate predictions. So if you get an answer that you don't like, you go back and you can tweak the model and go through a trial and error process until you get a result that is what you're looking for. Ultimately, you can also give this ability to the program. So you can let the program tweak the parameters on its own and essentially allow it to figure out for itself through massive trial and error, and by tweaking these data features to find which are the most salient and learn over time how to give you the answer that you want. Suddenly you have a program with a superficial but very real ability to learn on its own how to complete a task. Here's a very basic example I've made using a program called TensorFlow to illustrate the point. Say I want to construct a program that can successfully separate the two different types of data in this set, blue dots and orange dots. Obviously, they can't be differentiated using a linear function, but we can train a neural network to find which features are useful in separating out the relevant data. In the case of the first model, there's limited neurons and only 2 hidden layers, and it's just not powerful enough to generate features of sufficient complexity to be able to isolate the data points that we want. But in the second model, on the bottom, by increasing the number of neurons and hidden layers, more complex features can be modeled, selected, and combined. Here, now you can see the second model is able to generate features of sufficient complexity that we get a model that can identify the interface or the edge of the 2 different types of data points and accurately perform a very hard classification task. How does this all work? How do we figure this out? Well, it's all inspired in part by one of the original models developed by Hubel and Wiesel in 1965 for how the visual cortex works. They demonstrated how simple cells are sensitive to very specific features within an image. For example, a line in a specific orientation and in a specific location. It's not immediately obvious how data this basic can be manipulated to identify a complex shape, such as a square or a star, but by combining the inputs given by the simple cells with the highest weights, as represented by a higher rate of cortical firing, you can extract the strongest features within the visual field, for example, edges, and use those features to construct a complex and accurate output, or a representation of what is in the visual field starting with only very basic data points. A nice example of this at work today in artificial intelligence is in image recognition. How do we train a network to identify faces? We start with the most basic features of the data in the image, for example, pixels of different brightness, and combine and manipulate them to first find simple edges, then combine those edges into more complicated features until the network finds the most salient characteristics of the data set to give us the answer we want. For example, here, to learn to recognize a human face. So what does this all have to do with medicine? Well, as we all know, there's been an explosion in AI healthcare applications, and they're already making a big difference in how medicine is performed. The global AI and healthcare market is expected to grow from $5 billion in 2018 to $45 billion in 2026. And there's a table here showing all the AI technologies just for radiology augmentation that have been approved by FDA in just the last year. So how do we leverage the potential of this new technology in neurosurgery? Well, the clinical problem that I've been working on is improving the diagnosis of traumatic brain injury. Why? Because in the United States alone, TBI is the leading cause of mortality in people under age 45. It accounts for 2.5 million ED visits per year and costs $76 billion in lost productivity and treatment costs every year. There's another component that's interesting, and that's what I term the triage crisis. As we know, time is brain, and the key to ensuring the best outcome for TBI patients is to make sure they get timely care at a designated trauma center. However, up to 60% of severe TBI patients are under-triaged and admitted to hospitals that can't properly treat them. Even in urban areas, over 30% of patients are under-triaged. This results in an excess mortality rate of 25% in the United States. A big factor in this is the fact that our first responders don't have an affordable, reliable tool for the objective assessment of patients with suspected TBI in the field. Fortunately, as neurosurgeons, we have a powerful biomarker that we know about for TBI, the pupillary light reflex. PLR, the pupillary light reflex, has been shown to be the most important factor in the pre-hospital triage of TBI patients, the most sensitive predictor of 6-month mortality in TBI, and a reliable indicator of elevated ICP. For these reasons, first responders and clinicians rely heavily on the pupillary light reflex for the triage and monitoring of TBI patients. Unfortunately, no matter how highly trained we are, humans are just not very good at this task. Manual pupillometry, the process of using a pen light and the naked eye to assess the pupillary light reflex, is fraught with error. The literature shows that because of the subtle changes involved and the limits of human perception, even expert practitioners are subject to large inter-examiner discrepancies as high as 40%, making a human assessment basically meaningless in all but the most extreme cases. Despite this, it remains the only method for pupillometry available to the vast majority of first responders and clinicians in the US and throughout the world. We do have digital pupillometers, which are the current gold standard. These are devices that use infrared light to assess the pupillary light reflex. They're very accurate and they're very reliable, but they're also very expensive and they're very complicated. And they're fragile. They're not really appropriate for field use, certainly not in the pre-hospital triage setting, and certainly not a good use of resources in the majority of healthcare settings around the world. So my goal has been to use machine learning to use the iPhone for pupillometry. We want to fill this gap in functionality by using the tools available on the iPhone, a ubiquitous platform, to develop a cheap and effective pupillometer useful in and outside the ICU with the intent of making this objective measure of neurofunctioning accessible to a greater number of providers in a wider array of settings. The way that we do this is with the technology that we call pupil screen. We use the flashing camera on the iPhone to elicit and record a 6-second video of the pupillary light reflex at 30 frames per second. We upload that sample to our cloud, and we use a fully convolutional neural network, which I'll talk about in a second, to segment each frame of the video and determine the pupil diameter across time, generating what's called a pupillary light reflex curve, or a representation of the reactivity of the pupil. The results are then pushed back to the user of the iPhone. To train and evaluate our neural networks, the first thing that we need to do is generate reliable training data. So to do this, we hand annotated lots of images, more than 7,000 eyes in total. We manually identify the pupil center, the diameter, and then we select points around the pupil and fit it to an ellipse. By doing this from a series of video frames in sequence, we can get ground truth measurements with which to train and assess our own machine learning model. Our model currently is a dual convolutional neural network. Each pixel in the image is used as an input feature. That means there's 30,720 initial input features, which the first neural network processes to identify the XY coordinates of the pupil center. It then crops the image to 1/9 its original size and sends it to the second convolutional neural network, which then takes that cropped image and uses it to find the pupil diameter. It takes a long time to train these things, but once we finished training, we did a basic validation study. So the most basic function that a model like this needs to be able to perform is to estimate pupil diameter. That's what everything else is built on. So after the development and training of our first model, we performed this validation study and showed that our median error in terms of pupil diameter estimation was about 0.32 millimeters. And that's what's in what we call the superhuman range of performance. The eye is only able to physiologically determine a difference of about 0.5 millimeters of diameter change. So we're able to easily surpass what a human is physiologically able to do. We're also just about equal in terms of performance with the infrared pupillometer, which has a median error of about 0.3 millimeters. Diameter estimation is just scratching the surface, however. By measuring the diameter of the pupil in each video frame, we can also generate what's called a pupillary light reflex curve, a graphical representation of the diameter change over time. The most basic determination you can make by looking at this curve is the presence of pupillary reactivity. This is what a pupillary light reflex curve should look like in a relatively healthy person. For the next study that we did, we theorized that just by presenting the PLR curve to providers, we could improve the diagnostic accuracy of their assessment of patients with severe TBI. So we asked doctors and nurses to perform the same task, looking at the pupillary light reflex curve in normal and abnormal patients and determining which curves belonged to the abnormal group and which curves belonged to the normal group in order to judge reactivity. Our theory was that this method of visualizing the data would make a judgment much more straightforward than trying to do the same task by looking at a person's eye with a pen light and doing it at the bedside. It turns out we were right. By comparing the individual doctors' and nurses' assessment to the correct interpretation, a high Cohen's kappa coefficient demonstrated that individuals can reliably assess normal and abnormal pupil reactivity looking only at the PLR curve. The largest previous study into this phenomenon was this study down here in the corner of the screen, and it showed Inter-observer agreement of a kappa coefficient of about 0.4 for reactivity, and 54% agreement of pupillary size, which is really poor, and why I said earlier that manual pupillometry in all but the most obvious cases is basically meaningless. So our diagnostic reliability is much higher, and we're not doing anything other than just showing the user the graphical representation of the pupillary light reflex curve. So how does this make a difference in reality? Well, as the EMT at the scene of a car accident, you now have a tool to objectively diagnose each patient and send them to the correct hospital right off the bat. My hope is that providing an ability to accurately assess what we think is the most important biomarker for pre-hospital triage of TBI, that will be able to help reduce the problem of under triage of TBI patients and the concomitant excess mortality. Our validation study was crucial in developing a functioning version of the technology, and this has allowed us to expand the breadth of our research program. It also generated attention and taught us that the public was primarily interested in technology that would improve the diagnosis of concussion. And we know that there's a reason for that. Concussion has become a nationwide concern. Almost 4 million sports-related concussions occur every year, and half of these go undiagnosed. Well, say, so what? It's just a concussion. But in reality, these cost the US $60 billion per year in terms of treatment and lost productivity. And a concussion predisposes a patient to a 600% increased risk of future head injury. There's also a 15% risk of permanent cognitive deficits. So if there's such a problem, why are they so frequently missed? Well, it's because there's really no good objective diagnostic test for this yet. Fortunately, around 2015, the US military started to publish data that opened the door to an objective diagnostic tool for concussion. Again, the pupillary light reflex. Their literature demonstrated significant abnormalities of the pupillary light reflex curves of patients with concussion or mild TBI. Prior to this, there's no indication that pupillary light reflex changes occurred in these patients, mainly because the exorbitant cost of digital pupillometers had made them impractical for investigating this indication in the first place, and the unaided human eye can't detect the subtle relevant alterations in the parameters of the PLR curve that contain the relevant diagnostic information. What I mean by this is that looking beyond just pupil diameter in reactivity can tell us a lot. If we look at the actual morphology of the pupillary light reflex curve, we significantly expand the indications for which pupillometry has diagnostic utility. I'm talking about some of the parameters that are outlined here. Constriction latency, the time between which a light source is applied to the eye and when the eye actually starts reacting to it. What the actual velocity of the constricting pupil is in that constriction phase. What the amplitude of that constriction is. What the speed of the dilation happens to be. There are about 9 different parameters that these studies are looking at, and that in different combinations can almost perfectly discriminate between various pathologies that you would never have assumed pupillometry was relevant for previously. One of the most successful cases for this is in Alzheimer's disease. You can just see the pupillary light reflex curve in a normal patient is just to the naked eye different than that for an Alzheimer's patient. Why is this? It's because the autonomic nervous system is affected in Alzheimer's disease. And so the autonomic nervous system, being responsible for the pupillary light reflex curve, is likely to be impacted by the pathology underpinning Alzheimer's. And any type of pathology that targets or impacts any part of the neural circuitry that is responsible for generating a piece of the pupillary light reflex curve is likely to be picked up by some kind of an abnormal parameter in that curve. And what we're doing now is we've got a grant to work with the Seattle Children's Hospital to do the same study that the military has been doing in their soldiers with mild TBIs and concussion, but doing it in children that are showing up to the ER with symptoms of concussion. That's just getting off the ground now. Anyway, that's it. I'm happy to take questions. I have a couple more slides I can go over, but I wanted to leave enough time for questions. I want to thank Dr. Stieg, first and foremost, and Dr. Juthani for the invitation to speak. Dr. Hartle for bringing me here and supporting me, and really the whole Weill Cornell neurosurgery family. You've been incredibly supportive and welcoming to me. I really have enjoyed my time here so far. I'd also just like to thank the partners that I've worked on this technology with in UW, around the country, also in Thailand, a study that I haven't talked about yet, as well as the patients and their families and my funding organizations, which are listed here. Thanks very much. Any questions?
Hey, Lynn, how's it going? It's Gary, great talk. Thanks so much. I was wondering if you guys are planning or looking into the utilization in the ICU setting, and what it can mean for. It seems it's a really interesting technology for first responders and like when people first come in, or ED, but for like patients who are in the ICU for a prolonged period, and in that context, have you looked into it or planning on it?
Definitely. So one of the newer findings about the pupillary light reflex is that it's a accurate predictor of changes in intracranial pressure, which is why we use these digital pupillometers in the ICU. And in Seattle, I think from talking to you guys that it sounds like you use them here as well. They're a really informative data point for us in being able to tell how someone's doing who doesn't have an exam and who we don't want to have to bolt or take down for a CT scan. Unfortunately, the majority of the world just doesn't have the resources to be able to buy these things and implement them. So actually I'm going to go forward a slide or a couple slides, because one of the studies that we're doing is looking at the utility of this in the developing world. So instead of using a bolt or having to buy a digital pupillometer, can you use this app to replace one of those expensive technologies and have a way of monitoring patients, detecting neurological worsening, saving resources? CT scans, things like that are very precious in these situations, and trying to improve the level of care without increasing costs, and helping provide tools that allow these different healthcare environments to raise the standard of care that they're providing to the guidelines that we develop in the developed world.
Lynn, it's Roger. I had a question or two questions. How is this, maybe put that into perspective in terms of what, for example, Larry Marshall, he worked on this before, right? Maybe you can comment on that, how your work is different. And then there's a lot of interest also in eye movements, especially in the football world, where players can be scanned on the sidelines in terms of their abnormal eye movement. And how have you looked at how does your technology, how is that different from that? And is that something that would also be of value and could also be studied?
So eye gaze tracking technology is one of the main ways that people, I know Dr. Gadger, I met him, he's a great guy. He's working on eye gaze tracking technology for concussion detection. And the way I see that is that it's just missing the boat by one generation of technology, because to try to develop a literature that demonstrates that there are reliable and detectable changes in eye gaze tracking, you're having to build an entire literature from the ground up. It's also something that can be kind of gamed by players because it involves a voluntary component. So, for example, if you have an NFL player who's on the sidelines and he doesn't want to be taken out of a game, there are things that high school, college, NFL players are known to do to try to game the concussion assessment And eye gaze tracking is one of the technologies that can be gamed because there's a volitional component to it. I think the reason why the pupillary light reflex is such a compelling biomarker for concussion is because there's no voluntary component to it. It's a direct measurement of a neurological reflex. It's a direct measurement of neurological functioning that can't be tampered with, for lack of a better term. And as far as Larry Marshall, he was kind of integral to the development of the digital pupillometer. And I think the things that have prevented the digital pupillometer from making more of an impact worldwide is, first of all, the cost. And then second of all, the fact that because it uses traditional programming, the performance of a digital pupillometer is static over time. It has a certain degree of accuracy, and it's kind of capped at that level of performance because it's not based on a neural network. It's not based on machine learning. It can't improve its performance based on exposure to new training data. So that means, first of all, that it has no diagnostic capability. It can only display the characteristics of the reflex, you know, giving an NPI or some index that's a representation of the normality of the pupillary light reflex, but it can't make a standalone diagnosis. Whereas if you have a neural network and you train it on data and you teach it that this is the kind of a pupillary light reflex curve a normal patient has, this is the kind of a curve that a concussion patient has, or this is a severe TBI curve, eventually you can train it to be able to determine those differences on its own, and you have the capability of being able to provide a standalone diagnostic tool where you go beyond just demonstrating a physical parameter and go more towards offering a diagnostic tool. That's far down the road, but with the type of programming that we're using, at least that is a very viable option, and one that there aren't really many technological barriers to being able to execute.
Thank you.
Hi, Lynn. Great talk. Thank you so much for speaking. One of the questions I had was about how you take into account ocular pathologies and retinal pathologies, and if that can, you know, perhaps lead to misleading diagnoses, particularly in the field. You know, I understand it would track over time within an individual and you can follow their curve, but it could have significant effects on the first reading. And how do you anticipate taking that into account?
That's a great question. One of the first things that we ran into was, well, how do we know what a normal pupillary light reflex curve is? Because it changes over the course of your life. It's very different in a child of 2 years old versus a child of 16 years old versus an adult versus an 80-year-old. It's constantly changing. And so there have been developed some normative tables that help us to understand what a pupillary light reflex should look like in different age groups or in response, to example, to different medications. So what is a normal patient who's on some kind of an acetylcholinesterase medication expected to have their pupillary light reflex change in response to being on that cholinergic medication? All those things are understood in pretty solid terms, mainly because of the anesthesia literature, because they are dependent on pupillometry for assessment of anesthetic, and they are constantly having to interpret the pupillary light reflex in the context of having many different medications on board. So there are normative tables that help us to understand that. There are some pathologies that probably will exclude us from being able to use the technology in a really reliable way. Cataracts, things that prevent the light from getting to the retina in the first place. There are some things that probably will be no-goes for us in terms of who benefits from the technology, but in reality, those are patients that we're trying to use the pen light on in these kind of emergent situations anyway. And so it's not a problem that has been solved by any of the technologies that we use. And I think that if we have exposure to enough patients with enough different types of these pathologies, we can eventually learn how these pathologies impact the curve and potentially be able to squeeze a little bit more diagnostic utility out of it in those, specific patients.
Lynn, a quick question. I know I'm sure if you ever used Photoshop and try to select a certain color and so on, the smaller the differential, obviously, between a dark black pupil versus, say, a dark or a brown colored eye. I know you mentioned blue having obviously a relatively straightforward and low error rate. What happens with the brown eye or other colored eyes?
So that's a great question. And yeah, when you look at blue or mixed colored eyes, we actually blow away the digital pupillometer in terms of our accuracy. It gets down to 0.1 millimeters because it's just a much easier processing task to be able to find the interface between a blue eye and a black iris. That interface is much more obvious. Part of the reason why we decided to set up this trial in Thailand is because it gave us access to a lot of very dark brown irises that would help improve our accuracy when it comes to dark brown eyes. So yeah, that's the performance in brown eyes is what dragged our median error to 0.3, even though we were very good with blue and mixed colored eyes. So that's definitely something that's, so we're still, I think we're 0.38 in terms of the millimeters of error with brown eyes. So we're still well within the range of what's useful and certainly better than anything a human can achieve, but it is dragging down our overall accuracy. And yeah, that was one of the reasons why we decided to go to Thailand, was because we just wanted more training on what are classically the most difficult pupils to assess. The other thing that's relevant is skin color. So we have to make sure that we're taking samples from people of all different races, skin shades, because the color of the skin can, fool the algorithm. And we want to make sure that we're not missing anything in terms of potential confounders. So pupil color and also skin color and racial background are very critical to make sure that you have a wide variety in your training data to make sure you have the most robust model possible. Great question, thank you.
Lynn, what about ICP? Have you looked at patients in the ICU with various levels of ICPs, for example, and if that affects your measurements?
So we haven't ourselves done any study looking at ICP versus the pupillary light reflex, but there's a very robust literature demonstrating the correlation between ICP and the pupillary light reflex curve. There's this demonstration of pupillary changes up to 16 hours ahead of a neurological worsening event, which people have talked about as being a way of being able to kind of preempt neuro worsening. And that's something we're trying to tap into, but we just don't have the bandwidth really to be able to, on an hourly basis, look at ICP and pupillary reactivity and plot how they trend or don't trend together over time. But that's definitely one of the main things that we want to begin doing in the ICU setting next, going beyond pre-hospital triage and going towards optimizing care within the ICU.
All right, if there are no more questions, maybe just to wrap it up. So what's the big picture going forward? What are the next project or next two projects that you're working on?
So big picture is to continue doing clinical trials, the ones that we have set up in Seattle, around the country, with an end goal of being able to go to the FDA as a Class 1 device. We've got projects going on around the world, and we need to get feedback from the end user about what the app is actually like to use and what improvements we need to make it more useful for the end user. And like I mentioned before, when it came to concussion and Alzheimer's, we want to start to branch out into new types of pathology that might be amenable to utilizing a pupillometer for diagnosis. So continuing our ongoing clinical studies to collect data and go to the FDA, and then kind of simultaneously branching out into other pathologies that represent low-hanging fruit and where there's a need for a better diagnostic tool. Those are the two initiatives at the current point in time.
Well, we should talk about Tanzania because the ICU there has tons of patients and there's no ICP monitoring, and that would be great.
Yeah, that'd be a fantastic study site.
All right, Rupa, is that it?
Yeah, that's it. Tthanks so much, Lynn. It's great to have you.
Thanks very much. I appreciate the invite. Thanks for having me.